Doctor, please start now.
Good evening, respected seniors and my dear friends. Myself, Dr. Vaibhav Somvanshi, Consultant Neurologist in Ethos Hospital, Kota. Today we will discuss an important but underutilized tool from the neurologist armamentarium, that is TCD, which is transcranial Doppler. Today we will discuss practical aspects of transcranial Doppler with the pitfalls and how to solve those pitfalls in the form of troubleshooting. The application of the TCD is monitoring of the blood flow in the cerebral blood vasculature and sonothrombolysis, after effect of carotid stenosis, vasomotor reactivity, emboli monitoring, detection of vasospasm after subarachnoid hemorrhage, detecting cerebrocirculatory arrest, intracranial stenosis, and right to left shunt. Now we will come to the how to read the waveform of the TCD, in which we'll see such kind of panel where on the left side it is velocity scale, which is showing positive as well as negative. In the positive sides, the upstrokes are seen. We can see the upstrokes where the number 1 is showing the beginning of this systole, number 2 showing the peak of the systole, number 3 showing the diacritic notch, and number 4 showing the and diastole. And on the baseline it is the time axis, and on the right side we can see some numbers which is showing velocity as well as pulsatility index, which we will see in the coming slides. Now, how we will perform the TCD? There are different windows of performing the transcranial Doppler, where the skull bone is very thin, from where we can insonate the arteries and get the desired results. In which the important windows are transtemporal windows, suboccipital windows, submandibular windows, and transorbital windows. Based on the pulse echo technique, the 4 commonly employed acoustic windows in the adults, as I have narrated just now, the temporal, the flow velocities in the MCA, ACA, and the PCA, along with the PCOM, can be obtained. With the orbital window, we can see the flow velocity of the ophthalmic artery and the internal carotid artery siphons. With the suboccipital window, it will allow to insonation of the vertebral artery and the basilar artery. With the submandibular window, we can evaluate the distal cervical internal carotid arteries. With the transtemporal insonation, a red color signals towards the probe between the 40 to 65 mm, showing the ipsilateral MCA, and the blue signal between 65 to 80 mm distance, showing the ipsilateral anterocerebral artery, and the red signal beyond 80 mm, showing the contralateral A1 ACA, and the bidirectional signal obtained at the 60 to 70 mm represents the ICA bifurcation. With the transorbital insonation, the transducer placed over the eyelid and angled slightly medial and upward, the flow signals at the depth of less than 60 mm towards the probe, showing the ophthalmic artery, reading of the ophthalmic artery, and the ICA siphon is curved artery. The flow signal may be directed towards or away from the probe. In the ophthalmic artery, it is the pictorial and the graphical representation, how we will see the graphs of the graph waveform of the ophthalmic artery while insonating via the transorbital window at the depth of the 40 to 60 mm, which shows normally a mean flow velocity of 21 plus minus 5 centimeter per second. This showing the carotid siphon, which is at the paracellular region at the depth of 60 to 80 mm, which has the normal mean flow velocity of 47 plus minus 14 centimeter per second, with the pictorial as well as graphical representation. Suboccipital and the transforaminal insonation, we have to place the transducer just below and medial to the mastoid process, which is directed slightly medial and more horizontally towards the bridge of the nose or the contralateral eye. The ipsilateral vertebral artery between the depth of the 50 to 75 mm signal always away from the probe, which showing the blue color. By turning the probe slightly upward and medially from the depth of 75 to 110 mm, basilar artery may be insonated, which is also showing the blue color in the on the graphs. May also be obtained through the transforaminal window, the transducer just below the occipital protuberance and towards the nasal bridge. The flow from the basilar artery is also away from the probe. Submandibular window. This is the graphical as well as pictorial representation how to do the submandibular insonation. in which depth should be kept at the 50 mm and the direction is away from the probe. That's why it is showing the blue color and the window is retromandibular with the mean flow velocity of 34 with the pulsatility index of the 1.07. Now, what all are the criteria for the vessel identification? First of all, the cranial window. Which cranial window we are using? According to that, we can identify the certain vessels. And depends on the depth of the sample volume, we can safely say that we are insonating a particular vessel. And the direction of flow, whether it is towards the probe or the away from the probe, we can easily distinguish between MCA versus PCA, MCA versus ACA. The distance over which the vessel can be traced without branching, and the relationship of the terminal internal carotid artery, MCA, ACA junction, and the angle of transducer in the relation to the patient's head and the cranial window. Lastly, along with that relative flow velocity, as we know that in the MCA, it is the maximum flow velocity, mean flow velocity is there as compared to the ACA, as compared to the PCA or the basilar artery or the vertebral artery. Now, with this table, we can understand at what depth, what is the velocity and what is the direction of the flow of the blood in the particular vessel. In the MCA, at the depth of the 45 to 65, the flow of the blood is towards the probe and with the mean flow velocity of 46 to 86. At the ICA bifurcation, it is the bidirectional flow is there with the depth at the depth of the 60 to 65, we can insonate via the transtemporal window. ACA artery, we can insonate via the transtemporal window at the 60 to 75 depth, but the direction is away with the mean flow velocity of 41 to 76. PCA, P1 artery, the first part of the posterior cerebral artery via the transtemporal window at the depth of the same 60 to 75 mm, the direction of the flow is towards the probe, which is showing 33 to the 64 mean flow velocity. At the P2 artery, same the transtemporal window with the same depth, but the flow of the vessel, flow of the blood in the vessel is away from the probe with the mean flow velocity of 33 to 64. Ophthalmic artery, via the transorbital window, we can insonate at the depth of the 45 to 60 mm, which showing the flow of the blood towards the probe at the mean flow velocity of 21 to 49. At the supraclinoid segment of the ICA, via the transorbital window at the depth of the 60 to 75 mm, it is the flow of the blood in the vessel is away with the mean flow velocity of the 50 to 60. Now, what is there are some criteria: mean flow velocity, pulsatility index, peak systolic volume, end diastolic volume, mean flow volume, and the pulsatility index. How we will calculate it? Mean flow velocity is calculated by the peak systolic velocity plus 2 end diastolic velocity, and the pulsatility index can be calculated by the peak systolic velocity minus end diastolic velocity divided by mean flow velocity. Now, what all are the pitfalls or the shortcomings or the problems that we used to face while performing the TCD, and what all are the solutions or the troubleshooting that we can do while performing the TCD that we gain via the experience? The vessel identification. The only 30 to 50% of the population have the complete circle of Willis, whereas the other 50% has the anatomical variation. So we will definitely see some anatomical variation while performing the TCD, and accordingly we have to generate the report of the patient. And the PCA identification, sometimes we find difficulty in identify the PCA. In that case, to differentiate PCA from the MCA via the eye opening and the closing maneuver or the depth change, we can identify the PCA. Vertebral artery identification, compression of the extracranial vertebral artery against the mastoid assist in identification of the vertebral artery. Sometimes patient of the RTA or the decompressive craniotomy patients came for the TCD. In those patients, transducer must be placed either in front of or behind the sutures or staples with the Alara principle. Scalp edema or the flap bandages, we have to cut the bandage over the window area and adjust the depth. If we're unable to get the window, 10% of population may have hyperostosis, difficult to get the window. So we have to increase the power so that we can increase the get some window to insonate the vessel. In case of subcutaneous air, in which the post-operative, post-neurosurgical patients, either we have to compress the probe to remove the subcutaneous air from the window side, or wait for 2-3 days for resorption of the air. In the semi-comatose or the irritable patients, nuchal rigidity, we have to use the sedatives, painkillers, or manual assistance as the head holding. Now we'll come to the exaggerated vasomotor reactivity and the sleep apnea breathing pattern, which is defined as the wide fluctuation in the velocities associated with the change in the respiration. Here we can see that at the depth with the 2 megahertz probe at the depth of the 68 mm, when we are insonating the ACA, the mean flow velocity is 221 and the peak systolic velocity is 263. But just after 30 seconds, we'll find that the mean flow velocity is 168 and the peak systolic velocity is 226. So which one we have to consider? Whether we have to consider the mean flow velocity is 221 or we have to consider the mean flow velocity 168. So that is an irony. While performing this test, we have to consider any one value, because such a huge difference in the value cannot be taken as a normal. So in that case, the vasomotor reactivity is mean flow velocity at the hypercapnia stage minus mean flow velocity at the hypocapnia state divided by mean flow velocity at the rest multiplied by the 100. This is what we call mean flow. This is what we call vasomotor reactivity. The value of more than 65% indicates that normal vasomotor reactivity, while value less than 33% reflect the exaggerated vasomotor reactivity. So vasomotor reactivity between 33 to 65% represent the base borderline impaired autonomic control. So what is the solution? We have to monitor few rounds of the 60 seconds, few rounds for the 60 seconds and document the mean flow velocity swing. And with the mean flow velocity swing, we can get to know that whether the patient is having exaggerated vasomotor reactivity or not. Now, if the patient comes to us with the loss of autoregulation, in that case, as soon as the BP is increased, the mean flow velocity will also increase. And as soon as the BP will decrease, the mean flow velocity will also decrease. So if the patient is having some sympathetic surge or some anxiety while performing this TCD, when we can see this, such a huge variation in the blood pressure, simultaneously it will reflect on the mean flow velocity. So how will we tackle that? So in that case, spectrum saved to reflect the same pulsatility index as the rest of the segment of the external carotid artery, the baseline external internal carotid artery, the same PI we have to consider, and on that same PI, what is the value of the mean flow velocity and the systolic velocity that we will consider, and write it on the report. Now we'll come to some case vignettes. The case history in the left side of the panel, we are seeing that one of the CT scan which is showing the subdural hemorrhage along with that diffuse subarachnoid hemorrhage. It is the 74-year-old male on the dual antiplatelet agent for the cardiac stent, fell down 15 stairs and diagnosed with the diffuse SAH and the subdural hemorrhage with the admission GCS of 14. So in that case, we can see that we are hardly able to see any the frontal horns in this patient, which suggests of raised ICP. So simultaneously, we perform the TCD in this patient, which showing the spectral Doppler of the MCA, demonstrating the diastolic blunting secondary to the raised ICP, which is showing the pulsatility index of the 4.31, which is way high, and we found the ICP is found out to be having 46 mm of Hg. Following the intervention to reduce the ICP in the form of decompressive craniotomy and some osmotic reagents, there was normalization of the diastolic flow in the MCA and resolution of the high ICP with the pulsatility index of 1.65, and ICP came down to the 17 mm of Hg. Now the second case vignette, with the case history of 63-year-old male presented with the retroorbital headaches, diagnosed with the ACOM artery aneurysm, underwent into the coiling attempt. During the procedure, patient had IC dissection, transmural perforation, and pseudoaneurysm formation. CT head reveals diffuse SAH from the aneurysmal rupture with the IVH, and an EVD was placed, showed a raised ICP of more than 60 mm of Hg. A poor prognosis was given. The patient subsequently developed dilated pupils bilaterally and had hemodynamic alteration. in the sequence series of this TCDs, we can able to see that in the first picture, we were able to see that such a diffuse with the Fisher grade, modified Fisher grade 2 subarachnoid hemorrhage is there. With the first TCD showing the diastolic blunting, which suggestive of raised ICP. And the second picture is suggestive of diastolic flow reversal, which is ICP causing the reversal of the flow in the middle cerebral artery. And in the last TCD, we'll able to see that biphasic oscillating flow as an evidence of net zero flow, which suggestive of brain death. So with this TCD findings, with this TCD picture, we can this will help in diagnosing the patient as a brain death. Now the third case vignette, the case history: 50-year-old male admitted with a mild left-sided weakness, which had developed just 40 minutes prior to the presentation. Initial neurological examination revealed only left-sided pronator drift during the arm pronation test with the NIHSS score of 9, with the CT heads within normal limit. So here the first CT, and after 24 hours, this is the second CT, which is suggestive of right MCA territory infarct. So, if we cannot wait for the 24 hours, as the patient presented 40 minutes with the duration of the 40 minutes of the weakness. So we did the TCD, which suggestive of mean flow velocity of 95 at the M1 of the left side of the MCA, and on the right side of the MCA at the M1, the mean flow velocity is 20. So such a huge discrepancy is there, which suggestive of decreased flow in the right MCA at the M1 segment. So we immediately did the thrombolysis, and after the thrombolysis of we did the repeat TCD, which suggestive of mean flow velocity of 55 with the TB grade of the 3. So with the help of TCD, we will be able to get that whether we are successful in doing thrombolysis or not. Now, TCD monitoring during the intravenous thrombolysis, the beginning, speed, timing, and the amount of recanalization represent the important parameter for thrombolytic therapy for the stroke, and measured by the following 5 parameters. First, waveform change by more than 1 TB residual flow grade, appearance of the embolic signal, which is microemboli signals, transient high intensity signals of variable duration with the typical sound. With the flow, third is the flow velocity improvement by more than 30% at the constant angle of insonation. With the headgear, we do the TCD, continuous TCD monitoring at the particular constant angle of the insonation. Signal intensity and the velocity improvement of the variable duration at the constant skull probe interface, and gain sample volume and the scale setting. That we have to keep it at a constant level. Then only we'll be able to know that there is improvement in the flow velocity is there or not. Second thing, is there any microemboli signal is present or not? Appearance of the flow signals with the variable pulsatility index and amplitude of the systolic peaks. These are the 5 parameters that we have to monitor while doing the intravenous thrombolysis with the TCD monitoring. Now, what all are the limitations of this TCD transcranial Doppler tool, because of which it is slightly underutilized among the neurologist and the radiologist? It is the operator-dependent technique requiring detailed 3-dimensional knowledge of the intracranial artery anatomy. So the person who is performing this test should have the complete 3-dimensional knowledge of the intracranial arterial anatomy in his head. Secondly, TCD is hampered by the 10 to 15% rate of inadequate temporal window. Some of the patients is having osteopetrosis or having the thick bone. So that's why even after increasing the power, we were not able to get that proper temporal window. And in those patients, TCD is not able to give the proper benefit to the patient. And the most commonly seen in the Blacks, Asian, and elderly female patients, and most of the Indian patients as well. However, the temporal resolution and convenience of the TCD make it a vital asset to observing the evolution of the blood flow changes in the critically ill patient, those who cannot be shifted to the MRI or the CT scan machine. The patient who are on the ventilator, in those patients, we were able to get the important vital information via the TCD. The TCD, now comes to the summary. The TCD provides the real-time information about the cerebral hemodynamics and permits extended monitoring with the excellent temporal resolution, and advanced application of the TCD are integral part of the armamentarium of the neurologist for evaluating various mechanisms of the cerebral ischemia. Furthermore, TCD helps in planning and monitoring the disease process, effectiveness of the treatment, as well as aids in establishing the prognosis. So these are the references from where I prepared this seminar. Thank you.